All right, everybody, we'll be getting started now. Okay. All right. I'm David Gessert. I'm one of the sleep medicine senior staff. We're going to talk about sleep studies today. I know this is a pretty decent size of your guys' boards. So hopefully we'll be able to get you guys some extra points when you take your test. So there's a number of different kinds of sleep studies. We'll kind of go through all of these and talk about when to use them and when to not, and what the kind of the pros and cons are. Probably the biggest distinction to make first is, there are home sleep studies versus in-lab sleep studies. Home sleep studies, there's kind of two different versions out there. There's the traditional kind, and there's what's called a WatchPAT. We'll go into more depth on those. As far as in-lab sleep studies, there's diagnostics, titrations, and split nights. A diagnostic is basically what it sounds like. You're just watching them sleep to diagnose whatever problem they have. A titration sleep study is done with PAP therapy on, where they will adjust the PAP pressures throughout the night to optimize their breathing and treat whatever sleep disordered breathing there may be. And then a split night polysomnogram is one where you try to accomplish both the diagnostic and the titration in one single night. It definitely helps save a lot of resources and money to do the split night studies. It's also a lot more convenient for the patient because they only have to come in for one night. So here at Henry Ford, we try to do that as much as we can, just because we don't have enough beds to go around for the sleep studies. People are waiting, a month to get a test done. We'll talk about multiple sleep latency tests. These are done to attest the level of sleepiness, quantifying sleepiness. The most common use is for evaluating for narcolepsy. And then we'll talk a little bit about maintenance of wakefulness tests. And this is used to measure someone's ability to actually stay awake for a prolonged period of time. So the traditional home sleep test, there's three components to it that they have to wear at home. The equipment is given to them and they take it home, and the patient is in charge of doing it. There's an effort belt, which is basically a belt that goes around the chest. As the patient breathes and the chest wall moves, the belt can sense that, so we can kind of get an idea of how much muscle effort they're putting into their breathing. There's a pulse ox, and then there's a nasal cannula that acts as a flow sensor. There's no EEG on this, so there's no objective determination of whether they're asleep or not. It's all self-reported. So the best case to use this is someone who you have a very strong suspicion of sleep apnea. This really isn't something to use in the kind of like, gray area of cases or people where you're not 100% sure kind of going into it. It really should be used as like a confirmatory test, just so they can, qualify for the CPAP treatment. The benefits here is obviously it's very simple. They get to take it home and sleep in the comfort of their own bed. You'd be surprised at the number of people who come in for a sleep study and really only get like an hour or two of sleep just because they're uncomfortable in a strange place. It's much less disruptive to their life. They don't have to make arrangements for someone to take care of their kids or take care of their pets or their parents or whatever their responsibilities may be. And then it's also very cheap compared to the in-lab sleep studies. So a lot of insurances will kind of force you into this, and that's actually a negative about these tests, is that because they're cheaper, some insurances will require people to do a home sleep test first, even though you may think they need to do an in-lab test. One of the other big downsides to the home sleep test, the traditional home sleep test, is that they cannot be used to diagnose central sleep apnea, only obstructive. They tend to underestimate the severity of sleep apnea as well, so they can be falsely negative. Patients can pretty easily screw it up. Something falls off in their sleep, they're not going to put it back on, they're not going to realize it. So you get a lot of tests that come back too poor quality to actually use. There's no proof of who actually wore it. You give it to them, they go home, they can give it to their spouse or a kid or something like that. It's not that big of a deal. We're not too worried about this happening, but there are a lot of instances of people who have commercial driver's license and things where they have to be screened. And so they theoretically could be giving it to someone else to get out of it. The insurance limitations we kind of talked about. And then you really don't want to use this in anybody who has significant cardiopulmonary disease. Lower EFs, especially below 45%, really shouldn't do this. People with significant COPD, If they're on oxygen, you really shouldn't do a home sleep test. In fact, if they're on more than 2 liters of oxygen, the test can't register the flow good enough to actually make a determination. So anything like that, you really want someone to go into the lab. It'll give you a much better idea of what's actually happening with their breathing when they're asleep. This is what one looks like. You can see there's a nasal cannula. As the flow sensor, there's that belt around his chest. That center bigger piece is actually like the computer that like records everything. A pulse ox on his finger, and then there is a little microphone built into that computer that does pick up on snoring. And so it's pretty simple to put on. As long as they put it on correctly, hit the start button, it's usually pretty good. This is what a home sleep test looks like, at least through the software that we use here. The top half of this page is the whole night. You can see this is from 2 a.m. to about 8:30, 9 a.m. So that's the patient's whole night. Down here, you can kind of differentiate the bottoms into how much time you want to look at. Right here, this is a 3 minutes. And you can see this patient has a lot of these obstructive apneas where the flow is reduced. There's lots of snoring here. We'll go over more sleep study examples later on. But this is just kind of a brief look. You only get a couple things to look at here. You have the flow, you have snoring, the effort, pulse, and then oxygen saturation going down. It's the same categories in the bottom. So you're really just looking at a couple different things. The WatchPAT, this is kind of like the new hotness in terms of home sleep studies. The PAT stands for peripheral arterial tonometry. So you're actually measuring the tone of the arterioles in the finger. It's pretty simple. It's even simpler than the traditional home test. It's at minimum a test bracelet and a finger probe is really all it is. There's an optional effort belt and snore sensor. We always use those here at Henry Ford, but you could theoretically not do those if you didn't want to. With the effort belt, you can actually use this for obstructive and central sleep apnea. But again, you would really only use this WatchPAT home test in cases where you have a strong suspicion for sleep apnea. Again, kind of the same positives as the traditional home test. It's pretty simple. They do it at home. They don't have to spend a night anywhere. It is even a little simpler, like I said, than the traditional test. And then it does have the benefit of being, can be used for central sleep apnea. The same kind of negatives for this test. The patient can always screw it up. They cannot put it on right. Again, it can give false negatives. You still don't want to use it in people who have any significant cardiopulmonary disease. There can be a little more insurance limitations for these. Not every insurance will cover a WatchPAT. And kind of the biggest thing people will complain about, at least sleep people will complain about, is that you're measuring a surrogate marker here. You're not measuring any kind of airflow or breathing whatsoever. You're measuring blood flow basically to assess a breathing problem. So a lot of us aren't the biggest fans of this, but we do use them just because they are so simple. And they even make like disposable versions of these, so you can actually mail it to the patient, and then it connects through like an app on their phone, and they just throw it all away when they're done. So it can get even simpler, especially for people in like rural areas. This is what the test bracelet and finger probe looks like. With these ones, you can actually prove who wore it if you set it up correctly. The finger probe is a one use. Once they take it off, it won't re-register when they put it back on. So theoretically, a patient could come to clinic, you could put the finger probe on them, and they could go home, and then you would know that was the person who wore it that night. There is no effort belt on this gentleman here, but it would look almost identical to what the traditional sleep study looked like. This is an example of a WatchPAT. Again, this is kind of a 3-minute picture here. The top row is the whole night from 0 hours to 6.5 hours. So when you look at these, the PAT signal here, this is the actual tone, and you can see it kind of goes up and down. The PAT amplitude here is just like a linear single line graphical representation of that same channel above it. Beneath that, you have the pulse rate, then you have your oxygen, then you have your respiratory movements or your effort channel. Then you'll have your actigraphy. Actigraphy is just motion sensing. So it's basically like a gyroscope built into the device. So if they move, it'll register. You'll have snoring, and then you'll have body position. If they use the effort belt, the computer on there does use the gyroscope to determine what direction they're in. And then down here, the computer uses all the above data to kind of synthesize staging. So it's somewhat accurate for the stages, but it just differentiates between wake, REM, and then like regular sleep. There's no like N1, N2, N3 for these. So when you're looking at these, if you ever see these, and again, these are pretty new. This may or may not be on your board. It's like just coming onto the sleep medicine board. But just so you're aware of these, if you ever have to practice this. What you're looking for during the event here is that when the patient has the respiratory event, they're not getting enough oxygen, they stop breathing. The brain responds by sending a sympathetic nervous response through the body. It causes the decreasing the arterial tone here, so you have to see the tone drop. The pulse rate will increase, and they have the oxygen desaturation. So you kind of get this thing right in the middle here where like the PAT amplitude and the pulse rate kind of pinch together like that, along with the desat. Then you'll usually see some kind of movement on the actigraphy because the arousal that happens at the event, they usually move a little bit. And then they'll usually have a snore or like a choking noise they make that kind of appears on the snore channel. So this is a very classic looking obstructive event for this patient. Let's talk about in-labs because this is really what most people should be getting because most of the patients we see, in the health system here have other medical comorbidities and are pretty sick. There's a lot more that goes into one of these. They have an EEG. The picture up there is the EEG done for a sleep study. It's much more limited than what you're doing for like a seizure montage on a patient or something. It's really just 6 leads. There are 2 frontal leads, 2 central leads, and 2 occipital leads. And they have a mastoid lead on each side that is kind of used as a reference. They'll have an electrooculogram or an EOG. That's 2 leads on the eyes or on the sides of the eye muscles. One is above one eye, one is below one eye. That different placing allows for us to tell which direction the eyes are moving based on the actual signal in the sleep study. There are 2 or 3 leads on the chin to measure chin movement because that plays a role in sleep staging. It also lets us look for teeth grinding or bruxism. There's leg EMG, which is just 2 leads on each leg to look for small non-visible muscle movements. For airflow, there's a number of different things that can be used. The nasal pressure, the nasal cannula type device from the home sleep studies is usually used. In addition, people often use thermistors, which actually detect the change in temperature. Then if they're using a CPAP titration, the actual PAP device can measure the airflow the patient is generating. There's respiratory effort belts. Usually 2 are used, 1 for the chest and 1 for the abdomen. A pulse ox, body position, and then there's a 2-lead ECG, and then there will be video monitoring for the patient as well. So the use for these, obviously patients who are sicker, have cardiopulmonary disease, people who are already on oxygen, these are the people you definitely want to do in the sleep lab. If they have other sleep concerns, parasomnias, that's stuff like sleepwalking or sleep eating, you want to do those because you can get a better idea of if their body is moving in their sleep. Obviously, if they're going to do any kind of PAP titration, that has to be done in the lab. There's no one who can go to their house and adjust their PAP pressures. Sometimes we use oral appliances, which are mouth guard type devices that adjust the mandible to treat sleep apnea. People who get those need to be retested while they're wearing it to see if their sleep apnea gets better. And then for Inspire, if you've heard about these are hypoglossal nerve stimulators that are implanted that generate tongue protrusion to help open the airway. They have to go through specific in-lab sleep studies where we can adjust the voltages and see if their tongue movement is enough to treat the sleep apnea. So those people have to be done in the lab as well. The positives for this, very thorough, obviously, all the stuff we're monitoring, very high quality. If anything goes wrong, the technicians are there on hand to go in and fix it, make sure if anything falls off, they can put it back on the patient. Obviously, this can be used for obstructive sleep apnea, central sleep apnea, any of the other kind of sleep disorders. The negatives here is that it's very expensive. It can be multiple $1,000s to do one of these. The insurances usually cover the vast majority of it, so it's usually not too bad for patients. But it is a realistic thing. A lot of people, once they find out how much it's going to cost them, opt to go for the home sleep study. They do have to come and spend the night, obviously. So they do have to arrange for healthcare or childcare. And then it's actually somewhat uncomfortable. It's not painful or by any means, but I mean, this is kind of what you're hooked up to for one of these tests. This little cartoon here, I think, is probably in like every sleep PowerPoint lecture ever given, but it's a little nice funny joke. You can kind of see this gentleman here. He has the nasal cannula on. This is one of the eye leads and the other eye lead, one above, one below. Here is the EEG on top. These are the chin. He has 3. And then you can't see the stuff on his legs. He has an EKG on underneath there as well. But he has all this stuff, and it's all plugged into this control board here. And then he's plugged into the wall, and he has to go to sleep. It's best to try to get a good night's sleep. They have to get up and use the bathroom. Someone has to come in and unplug them really quick so they can get up and go. So that can cause some problems for people who have incontinence and things like that. But obviously, that's not as comfortable as just sleeping at home with that simple little device on. So let's look at some squiggles. This is just kind of a quick example. I just want to kind of point out what we have on here. Something to always pay attention to whenever you have to look at these is that the order in which the things are is not standardized. They could give it to you in any kind of arrangement, so pay attention to what each thing is. The top here, we have the eye leads, so you can see the eye movement. Then we have his chin. Then we have the simple EEG. We have the simple 2-lead EKG. These here are the legs, so we can see muscle movement in the legs. If you look through here, you see a lot of EKG artifact coming through. So a lot of stuff can blend into the other lead, which makes things more difficult. This here is the snore channel. Then we have the nasal pressure, and then this is the thermistor. So we have 2 things measuring airflow, and then we have 2 things measuring the effort, the chest and the abdomen. Then you have the pulse ox. And then on this one, there was a TCO2 monitor. So in case if they're looking for hyperventilation, they can monitor CO2 values overnight. So that was the traditional in-lab type things that you would use for sleep disordered breathing. Now some of the specialized tests, and this stuff could be on your boards as well. Mean sleep latency testing. This is the test for severity of sleepiness. This requires 5 naps done during the day. That's a little kind of misnomer there, is that it's done during the patient's wake time. So if someone usually sleeps during the day and is awake at night, then this would be done overnight. And it's done immediately following a regular in-lab polysomnogram. So what you're really looking for in these 5 naps is how fast do they fall asleep, if they fall asleep, and do they achieve any REM sleep during the naps. The real use here is that you're actually quantifying the patient's sleepiness. The most common use is for narcolepsy or other central hypersomnias, so idiopathic hypersomnia, Klein-Levin, those kind of things. But most often narcolepsy. It can also be used to assess sleepiness after treating other sleep disorders. Some people, even after you treat their sleep apnea, are still overly sleepy, and so you can kind of reassess and see how sleepy they actually are. The pro for this test is that it's the only test we have for sleepiness, right? It's the only thing that's actually going to tell us how sleepy people are. It's somewhat objective. It's not just someone saying, oh, I'm really tired all the time. So it gives us a little bit of kind of hard data to use to help figure out what's going on for people. The problem with this test is that it's non-specific. It doesn't actually tell you why they're sleepy. There are lots of research done, using these tests on people who work different shifts. There's even tests used on residents working in a hospital, and find that they have tests that are consistent with narcolepsy just because of the hours and the sleep deprivation they have. So it doesn't tell you anything about why. You still have to have a good clinical picture to kind of identify what the actual problem is. And there's lots of different things that can confound the results. You have to stop certain medications, a week or 2 ahead of time. If people are on any kind of stimulants, they have to come off of them. If people are on SSRI antidepressants, they have to come off of them for a couple of weeks ahead of time. And that can be really hard to do because a lot of people really depend on those for their treatment of their mood disorders. So you have to kind of take all that into account. The other thing is just people who, maybe have a newborn at home or something and they don't sleep very well for the week leading up to this test. That can mess everything up. Maybe they just stay up late watching TV or something. There's lots of things you have to take into account when doing this test. Moving on to the maintenance of wakefulness test. This is also done in the lab, and this is to test someone's ability to stay awake. So what happens is the patient sits up in bed, leaning up against the headboard. There's a light off to the side, and they just have to stare straight forward and try to stay awake for as long as possible. They can't move significantly. They can't talk or hum or anything like that. They do 4 of these attempts lasting 40 minutes each and see how long they can stay awake. We use it because you need to see if certain people can stay awake. People who are pilots or drivers, they have to make sure that they're able to actually function at their job. It's also used to assess how do people respond to stimulant therapy. So if you're treating someone with narcolepsy or something like that, you can do this test then to see how they're doing with the stimulant use. It's the only test we have for this kind of thing. So that's, it's kind of its own unique thing. But the problem here is that it's, costly again. It's a long duration. They're spending, most of the day, because they don't just do 4 attempts back to back. They space them out by an hour or 2. So they are there for like a good 8 hours, 9 hours to do it. And again, lots of different things can mess up this test result too. So you have to take into account everything going on with the patient. All right, so now let's look at a bunch of sleep examples here. We'll kind of go through what makes each sleep stage. So there are 5 stages to be aware of. There's wake, NREM 1, 2, and 3, or N1, 2, and 3, and then there's stage R or REM sleep. Staging is done in 30-second epochs. That word looks like epoch, it is pronounced epoch. Staging is very fluid. There are a lot of things that are kind of borderline. Someone may not, 2 physicians reading it may not agree on the same staging. EEG frequencies you kind of need to know, and then there are examples to the side there. So alpha is 8 to 13 hertz, and that's drowsiness. And we'll show a lot of real examples of this. Beta, this is greater than 13 hertz. This is alert and awake. You won't see too much of this on sleep studies because it should be being done when they're somewhat drowsy. Theta, this is what's going to make up a lot of the sleep study, and this is 4 to 7 hertz, and this is N1 and N2. The diagram over here is slightly misleading. The amplitude of theta waves are usually not this big compared to alpha, and you'll kind of see what I mean. And then delta waves, these are really slow rolling waves, less than 4 hertz. This is really indicative of N3. This stuff is really obvious to pick out in the sleep study, and we'll kind of show you that too. So again, kind of different examples. This is what awake, non-drowsy sleep would look like. Stage 1, very, very similar to that. Kind of hard to tell the difference. Stage 2, and we'll talk about K complexes and sleep spindles. And then stage 3, the more obvious stuff, and then REM. So let's talk about the drowsy wake sleep. This is what the very beginning of most sleep studies are going to look like. You're going to have this alpha rhythm with this really kind of uniform amplitude, somewhat, fast waves. Other things you can see is some eye blinks. So this is actually during the calibration period. They always have patients do all the different movements and blinking and everything. But you can kind of see how the eyes move here. So they're conjugate movements, but they're also kind of opposite movements. And this is the patient blinking 5 times in 3 times in 1 second, and then 2 times in the next second. So you can see stuff like that when they're awake. As they kind of get really drowsy and are starting to transition into sleep, you can start seeing more slow rolling eye movements, or these more sinusoidal eye movements. They can even have some rapid eye movements when they're awake. If they're reading or if they're looking around, you can get a lot of rapid eye movements. And so for the eyes, you'll see these kind of more acute angle, sudden peaks and returns, really pointy edges. With the rapid eye movements, you'll have high chin tone compared to low chin tone, which is more something you'd see in REM sleep. So you can kind of compare that back and forth. But right underneath the eye, this brown bar was the chin. So you can see, especially in this example up here with the slow rolling eye movement, there's a lot of chin activity. When you should score something as wake is if over 50% of the epoch is this alpha rhythm, okay? So if you see 50% of it is alpha, you can call it wake and move on. This is an example. This is from one of your guys' review books. Yeah. Oh, on the video? Yeah. You wouldn't see it on the video because it's not going to be close enough to see chin movement. So most of it you're just going to do based off of the actual lead. If they're grinding their teeth, sometimes that's loud enough you can hear that on the microphones. But yeah, you're not going to get close enough to see that on the video. This is kind of what the alpha rhythm looks like here, and kind of a good example here. The eye leads are beneath the EEG, so different than the other one I showed you. But here you kind of have this alpha rhythm, this somewhat uniform relatively high frequency waveforms going throughout. And then this black arrow here is pointing to some small, slow eye movements at the end of that. Next, people usually go in order as well as they go to sleep. So the next stage when they fall asleep is going to be stage 1 usually. You're going to have theta rhythm. You can have more of the slow rolling eye movements here. Even though they're asleep, the eyes can still be moving in N1. You're going to get what's called low amplitude mixed frequency. So remember this because this makes up a large portion of sleep. So this example here to the right, this first half, that's the alpha rhythm. And then that right in the middle there is where they actually fell asleep. And they went into the low amplitude mixed frequency. And so you kind of see that change for when someone falls asleep. You can also see what's called vertex waves. And these are these kind of sharp, pointy waves that can appear. These are kind of uncommon, somewhat rare, but they are indicative of N1 sleep. So if you do see those, that can give you another hint as to what stage you're in. But again, the low amplitude mixed frequency, you got to kind of be able to pick that up and see where that occurs. And it just kind of looks like really small squiggly lines, like it's nothing really, that stands out to you when you see it. When you score N1, is if 50% of the epoch is that low amplitude mixed frequency, and there are no other signs of other sleep stages. So this is kind of like if you see something, they're asleep, but there's nothing else that jumps out, you can score it as N1. So this here is an example of N1 from the review book. Again, low amplitude mixed frequency, really nothing that jumps out at you on here. There's like a slight rolling of the eye there, but nothing here that is really, interesting to say. So next is N2. Again, more theta rhythm. You're going to have more of the low amplitude mixed frequency. And then you're going to see either one of these two things, a K complex or a sleep spindle. So a K complex is going to be pretty obvious. It's going to jump out at you. It's a sudden deviation with like a spike up or down. And it kind of, just jumps out like a mountain peak in the middle of the sleep study. A sleep spindle is going to be these kind of rapid, sudden bursts of waves that occur. It almost kind of looks like someone highlighted part of the sleep study in a black marker. Okay, it's going to stand out. You're going to notice it if it's there. And either one of those, if you see one of those, it's stage 2, okay, N2. If someone is in N2 and they have an epoch with, K complex in it, and the next stage doesn't have a K complex in it, it's still N2. You don't revert back to N1 at that point, okay? So you want to score N2 if there's low amplitude mixed frequency and any K complexes or sleep spindles. And you want to score all subsequent epochs as N2 until there is something that breaks up that sleep, whether it's a jump to N3, a jump to REM sleep, they wake up, they have an arousal. And again, that's even if there's no more K complexes or sleep spindles. Like I said, the K complexes really easily stand out. It's like a sudden change. It's a larger deviation from the mean, a bigger peak here. This is kind of a little more subtle sleep spindle. We'll see some other examples, but again, it does kind of look like there's more rapid waves there. So here, the sleep spindles stand out a little bit more. You kind of get these darker, thicker areas. So you see that, that's stage 2. This here is kind of a small K complex right in the middle. But again, another example of stage 2. So stage N3, this stuff is going to be really easy to pick out. It's basically going to look like a bunch of K complexes happening throughout the study. That's kind of the simple way to put it. It's delta rhythm. The waves are slower. They're larger. It should, like I said, it should be pretty obvious. This is like 3 points if they ask you to stage one of these, okay? What you want is 20% of the epoch to be these slow, large delta waves, all right? And you can see kind of how obvious everything is just kind of all over the place in that example there. But here, I mean, like there's no low amplitude. The amplitude is much higher. There's a bunch of those peaks. That's definitely 20% of that epoch. So you'd score that as N3. Lastly is stage REM. Again, low amplitude mixed frequency is kind of the baseline here. You're going to see rapid eye movements, hence the name. There's going to be low chin tone. Chin tone is kind of hard to assess on a single epoch because if they're not actually moving their chin, the actual just like thickness of the line can be different. So if you were seeing like this example here, there really isn't any movement there. But if you compared it to the same person in the sleep study, when they weren't in REM sleep, the line would be just thicker because there's just more kind of underlying tone. So it's kind of hard to use that sometimes unless you're actually going through a real sleep study where you can see the tone drop off as they go into REM sleep. You can also get these sawtooth waves on the EEG. You know, the name is kind of descriptive for them. These will usually occur right before people have bursts of rapid eye movement. So you kind of see that, and then right next to it, the eye movements will kick in, and that'll happen over and over again during REM sleep. But you don't always have sawtooth waves. They don't have to be there, but they usually are. You want to score REM sleep when there is low amplitude mixed frequency, there's no K complexes, there's no spindles, you have low chin tone, and rapid eye movements are present, okay? If they give you any kind of example on your boards or anything, they're going to give you all with obvious rapid eye movements. It's not going to be, you know, some weird, subtle form of REM or anything like that. So we'll have an example here. The black arrow is the low amplitude mixed frequency. The red arrow is obviously the eye movements. And again, the sharp, pointy, jerky eye movements. And the green arrow is the low chin tone. But again, you're not going to see big, you know, movement on the chin, but it's hard to kind of use something like this to compare without seeing earlier evidence from the same sleep study. So let's talk a little bit about respiratory events. So here, quick example of what they're going to look like. The top half here are central events. You have the airflow and then the effort. So with a central event, you're going to have lack of flow and lack of effort. The bottom half is obstructive. You're going to have lack of airflow, but you're still going to have persistent effort. For apneas, it's a drop in flow by 90%. It has to be longer than 10 seconds or longer in duration. If it's shorter, you can't count it. It's 9.9, it doesn't count. For obstructive, like I said, you're going to have persistent effort during the event. For central, there's going to be no effort during the event. Then there can be things that are mixed, where they kind of start off central and then effort builds as the event goes along. And that would be classified as mixed. For apneas, these are best seen on the oral nasal thermistor. So if you have both a pressure and a thermistor, and the pressure is flat, but the thermistor is still, you know, full 100%, you can't call that an apnea because the patient's still breathing, but the nasal pressure may not be picking it up because they might be mouth breathing or something. So this is an example of an obstructive apnea here. We'll just focus on the bottom half. Pressure and thermistor, both flatline, all right? And in the chest and abdominal effort belts, there's still movement throughout both of these. The effort can oftentimes look reduced because if you're completely blocked and you try to breathe, like you can't move your chest as far and your abdomen as far because you're not pulling any air. You can only create so much of a vacuum inside your own body. So the effort can be reduced, but it'll still be present. So this is very classic looking obstructive apnea. At the end of the first apnea here, this is what an arousal looks like on the EEG. You can see there's sudden change in the EEG. It's very disrupted. There will usually be some kind of movement and usually some kind of snore at that same time with that arousal. Okay. Essential apnea, basically a flat line on all of them. This here was done with the CPAP on, so that's why there's only one flow monitor. But the flow flat lines, effort flat lines, and that's essential apnea. Mixed apnea, again, everything's flat lines for the first portion. Effort kicks in towards the end, then they have their arousal. So that would be classified as a mixed. This is just an example of severe OSA. This is a 2-minute page here. So this is 2 minutes of the patient's breathing. And I think I counted it the other day. I think if they breathe 7 times in 2 minutes, and the rest of it is apneas. Okay, so for a lot of people, this can be pretty severe. This would be roughly like an AHI of like 60. And there are lots of people who have AHIs even higher than this, you know, 100, 150. I think the record at Henry Ford is like 188. So people can spend more time not breathing than breathing. All right, hypopneas. This is where things get a little more nuanced. The drop in flow only has to be 30%. It used to be 50% back in like 2015. So people who have old sleep studies, they can also be underestimating the severity of sleep apnea based on today's scoring rules. So a drop in 30%, again, duration 10 seconds or longer. The difference between hypopneas and apneas, though, is a hypopnea has to cause some kind of consequence. And the consequences we use are either a 3% drop in oxygen or an arousal on the EEG. So if there's a drop in flow that lasts for 12 seconds, but nothing happens because of it, doesn't really matter. You would classify a hypopnea as obstructive if there is any snoring, any inspiratory flattening, or what we call flow limitation, or if there's any thoraco-abdominal paradoxing on the effort belts where they actually go asynchronous as opposed to asynchronous. So if there's any one of those three things, you classify as obstructive. If all three of those things are absent, that's when you would classify a hypopnea as central. These are best picked up on the nasal pressure transducer and not the thermistor, so kind of the opposite there as well for the apneas. So this is an example of a hypopnea here. You see that the flow is still somewhat present, but it's definitely a drop of at least 30%. The effort was still present through these. Same thing here, and then there's an arousal right here, and there's an arousal right here. So both of those had some kind of consequence. It looks like the oxygen drops here, but you can't really tell by what percent. So again, you have to have the consequence or else it doesn't count. This is an example using our software. You can see here in the epic that's number 417. This is kind of what the baseline flow looks like. It gets much smaller, but there's still some movement on there. Still has persistent effort. And then we have the arousal on the EEG up here. So that one got scored as a hypopnea. And there was an oxygen drop from 95 to 91%, 4% drop. So let's just go through some examples so you can kind of try this out a little bit. All right. Anyone want to take a guess at what stage is this and tell me why they think it's that? So you think this is a K here? Okay. Any other guesses? Let's start with this. This is kind of the way I would go about staging something, kind of the way I would think about it, is start by looking at the EEG, okay? Give a little extra emphasis to the occipital leads. Stuff tends to look a little clearer down there than in the rest of it. Go through and decide, is this low amplitude mixed frequency or not? So basically, are they awake or are they asleep first? So do you think this is low amplitude mixed frequency? Or do you think this is more that alpha rhythm where they're awake? You think it's low? So it's not. This is alpha. Okay. So you're going to have more uniform, fast waveforms like this. There's obviously all kinds of things that can interrupt it and make it look weird. You know, the eye movements here kind of disturbed the EEG. Okay, so that wasn't a K complex. It was actually because of the eye movement. And again, this is stuff, you don't look at 10 of these every day. So so this is the alpha. So after you go through the EEG, decide if they're awake or asleep, then start trying to decide what stage of sleep they're in. So the next step would be to look for spindles and K complexes. Okay, this did kind of look like a K complex, so that was good that you at least noticed that. After that, if you don't see any of those, then you want to start at top and go through looking for any rapid eye movements. Nothing here that looks like real clear rapid eye movements. This kind of is somewhat rapid, but not rapid enough. And that's really the only instance of it. You can look for the chin tone. And then, the bottom half, the breathing, you're not really going to look at respirations for staging very much, okay? So EEG, look for alpha versus low amplitude mixed frequency. Then look for K complexes or sleep spindles. Then look for the rapid eye movements, all right? So that was stage wake because of the alpha rhythm. And then there was a little bit of like slow rolling eye movements at the end, but nothing that was rapid. And again, those are pretty subtle as well. So what do you guys think about this one? Is it alpha or low amplitude mixed frequency? Okay. I agree. K complexes, sleep spindles, do you see either of those? Okay, which ones do you see? Both. All right. So yeah, sleep spindle right here in the beginning, K complex here, almost right in the middle. We'll go up, no rapid eye movements, little bit of like chin activity at some point, but nothing crazy. So what stage do you think it is? Right, N2. So exactly what we said, low amplitude mixed frequency, sleep spindles, K complexes, you got it. What is this? Yeah, this one's pretty obvious, very large REM eye movements here. They're overlapping the EEG. Again, no alpha movement, it's low amplitude mixed frequency. You do get a lot of interference here from each other. You can see that the EKG bleeds into the EEG and you have the EKG QRS complex showing up. So that gets in the way. Then you can see with all the rapid eye movements, that messes up the EEG as well. So it almost makes it look like there's like these delta waves in the middle. So you have to pay attention because this stuff just happens and they will give you stuff that might look like that on the boards. It's not as clean. But thankfully, the rapid eye movements are very obvious. So everything kind of stands out pretty easy there. All right. What stage do you guys think this is? Or do you think it's N2?
Low and mixed, like mixed frequencies for the old lead, and then that looks like a K complex, and then the beginning looks like spindle, right?
Yes, very good. So exactly what she said. K complex here, a little bit of a sleep spindly looking thing here. No alpha waves, no REM movements. This is pretty good N2 sleep. All right, what do you think about this? So alpha or low amplitude mixed frequency? Is it alpha all the way through or part of the way through? Okay. Any K complexes or sleep spindles? No. Any rapid eye movements? No. So those aren't, you said in the beginning, those aren't rapid, those are more slow rolling. Okay. All right, so we have some alpha and we have some low amplitude mixed frequency. So what was the cutoff for determining which one you go with versus wake or sleep? 50%. So to break it down to 50%, at least on this software, I don't know if you guys can see the white lines, the white vertical lines. So each column is 1 second, okay? So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds here of what looks like alpha before it goes into low amplitude mixed frequency. Then there's more alpha here towards the end. So 11, 12, 13, maybe 14. So that's less than 50%. So this will be scored as N1C. All right. And obviously there's no other features here to determine. So this is a good example of that sleep is somewhat fluid, especially transitional sleep. When people are falling asleep, it's not just like they turn off and then they're in sleep. They kind of go in and out of it for a little bit sometimes. And you can kind of have this mixed thing where part of it is N1, part of it is alpha. Maybe the next epoch after this, there's 16 seconds of alpha and they're awake again, but they fell asleep technically for 30 seconds. But they weren't really asleep for 30 seconds. They were asleep for 16 seconds here. So it does differ a little bit. You do kind of have to pay attention to this kind of stuff. And they could easily give you something like this. You got to count it up or estimate, what takes the majority. What about this? So awake or asleep? Okay, good. K complexes or sleep spindles? All right. No rapid eye movements. What about the amount of K complexes? Lots of. So more than 20%? Yeah, I think so. So if it's more than 20%, what would you call it? N3. So that's delta rhythm for 20% of the epoch. So like I said, that stuff is usually pretty easy. It usually stands out that it doesn't look like everything else. So All right, what are we looking at here? And this is a minute, not 30 seconds here. So obviously we're talking about respiration now. So an obstructive event, that's good. All right, is it an apnea or a hypopnea? So the difference was how much flow reduction. So we come down here to pressure and thermistor, use this kind of as what normal might look like, because there's actually some flow here. So is this a drop at 30% or 90%? So it's almost a whole percent drop. So that would make it an apnea. Then look down at the effort. There isn't much on the chest, but there's definitely something on the abdomen, okay? So that would be obstructive, right? So obstructive apnea for this one. Although you can't see the full event here, what do you guys think about the second one? Mixed, yeah. So it definitely starts out with no effort on either of the belts, and then a little more effort shows up towards the end. So that one is a mix. So we have an obstructive apnea with an arousal immediately followed by a mixed apnea. Now, it is somewhat normal for people after an arousal to have a central event. So like all of you guys, if we did a sleep study on you, there's going to be some arousals during the night, and you might have a central apnea following them. It's normal. And that's probably what's happening here. This central portion is probably because of the arousal, and then because of that, they immediately obstruct again. So, but it was still scored as mixed, okay? What do you guys think is happening in this one? Yeah, so this is going to be a hypopnea. Yeah, so you have an arousal here towards the end. So if you kind of see that jumps out at you, you can kind of look back at what maybe caused it. You can see here, this is the flattening we're talking about. Okay, so if something's going to be obstructive, you're going to see this kind of flattening. You're not going to get this more peaked or rounded top here where there is a little bit more normal. Sometimes it can even be like scalloped. Like you kind of see this one almost kind of has this like U-shaped top to it. So that's a sign of flow limitation. Okay, so that's one of those three things that makes up a hypopnea. There's snoring during it, so that also means it's obstructive. So snoring, flattening of the flow curve, those are two signs it's obstructive. There is no real thoraco-abdominal paradoxing here. So you kind of see that the belts move together. They both kind of move up at the same time and down at the same time. When there's paradoxing, it very clearly flips just during the event, where they actually kind of come together and then go away and come back together. So that stuff would stand out too. So if you just had that, but there was no flattening or no snoring, you could still call it a hypopnea. So that's what it looks like when it's scored. They highlight it. All right, what do you think's happening here? I heard someone say central. So that's good. So obviously there's loss of movement here and then the respiratory. So no flow. So it goes from full breath to zero. So that's going to make it an apnea. And there's no effort there on the bottom. So again, that shows that it's central. Okay. So that's a central apnea. This patient was actually Cheyne-Stokes breathing. So if you actually had taken the same sleep study and zoomed out to like 5 minutes, it just has the same pattern of this waxing and waning breaths. As you can kind of see here, the breaths slowly build up. They get a maximal right in the middle, and they slowly kind of wane off and they flatten. So they just had event after event after event. All right, that was everything I have for you guys. Are there any questions or anything? Yeah. So it's just kind of electrical discharge from the brain. They come from different areas, and they just kind of find that that only happens in what we classify as like N2. And as you kind of think of it, N1, N2, N3 in that order, they get deeper and deeper sleep. So N2 is just a sign that N2 is a sign that you're a little bit deeper than N1. The majority of a sleep study is going to be N2 sleep. All right. You know, the K complexes, they arise from the cortex. There isn't really much that's going to be relevant to you guys on that. It's just to kind of know them for the sleep staging in case they give you anything like this. Yeah.
Do they have to leave the clinic and they had a patient that they completely sleep in the recliner or like the seatbelt? Is that possible during in vaccine study?
Yes, yeah, we do sleep studies in reclining chairs. If that's the way the patient sleeps at home, you know, there's no point in making them sleep completely flat in bed if they're never going to sleep that way at home. So we do that. We do usually try to ask people to try sleeping lying down, but they can toss and turn whatever position they want. You know, sleep apnea, both obstructive and central, is usually worse in supine position and lying flat, obviously. But yeah, we can do recliners if people need that. We even use wedge pillows for some people, or give them 10 pillows if that's what they want. But we just do what we can to make them comfortable and kind of simulate the home environment. Anything else? Yeah.
After an apnea, do patients who go back to pain or do they go back to as well? Or does the stage start back over again? Mild arousal to back experience?
So you would basically just score it as whatever it appears to be. So they can go back into pretty much anything. If it's a really small arousal, like this one, the patient went right back into what is basically N2 sleep, okay? But you would still have to score it based on what it is. So if they arouse and then in the next epoch, there was no K complexes or spindles, you would score it as N1. If there was a K complex, you would score it as N2 at that point. If it's in REM sleep and they have an arousal like that, a lot of times they may go right back into REM sleep. Sometimes they wake up from it and then they're awake for a while. I mean, it really depends, but they could go right back in. Yeah. Any other questions? Yeah. So there's kind of two parts to that. One is medically, what do you need? Medically, you really only need a titration study. All right. Like if they didn't lose weight, they're still going to have sleep apnea. It's not going to go away. Insurance-wise, that's where things are a little more difficult because sometimes the insurance companies want a new diagnostic study, especially if you don't have the original sleep study, you're definitely going to need one. So that's where it gets a little more finicky. If you want to do it all yourself, you know, let us know. We can kind of guide you. Otherwise, just refer them to our clinic and we'll dig through everything and figure it out. But yeah, if you don't think anything's changed health-wise, titration study is all you need. All right. Well, I will end there. If you guys have any questions, please feel free to reach out to me. Dr. Bazan is always around. You guys know Kareem, he's here too. So feel free to reach out, okay? You're welcome.